Hi, good afternoon, everybody. We've started the recording, if that is okay with everybody, and please keep your cameras off in terms of privacy reasoning. We have a great session for you today. Thank you for joining. We have multiple subscriptions as well, but I think because of the good weather, most people will prefer watching the recording instead. In any case, let's get started. We're so happy to welcome you to the session around maternal health and abortion awareness. We are presenting the session through Incision Ghent and Incision Belgium, which I'm going to tell you a little bit more about in just a second. Next slide, please. Great. Okay, so global surgery, one of the standing committees inside PEMSA, but is a global problem. And I'm not sure most of you in the audience are aware of this, but over 5 billion people currently don't have access to safe and affordable surgical care when needed. And if you look at the world population, this is the majority. Next slide, please. And the inequalities in surgical care are quite surprising and concerning, because if you look at the difference between high-income countries and low-income countries, touching back on those 5 billion, you can see on the pie charts the really big difference between the access in lower and lower middle income countries versus high income countries, where in these settings 93% don't have access to proper surgical care. And you might wonder, okay, what does this mean? It means a lot for lives there. For example, if you're a growing up boy and you do football and you break your leg, that means your entire life will look differently. It will mean that you have to find some way to transport to the hospital if there is even any kind of transport available. If you get there, let's hope there's a surgeon there, an orthopedically skilled surgeon. There's commonly a low coverage of proper anesthesiology. So that means just getting there is a big problem. The second problem is, of course, the cost. So just breaking your leg could disrupt your entire future, causing you not being able to walk, for example, or causing financial ruin to the people around you. So big impact, a very important topic. And the reason why we're organizing these sessions is because this is not very commonly mentioned, but in medical education or in common media. So to involve more medical students and get more awareness on this topic, we're organizing these sessions. This one is situated around maternal health. Next slide, please. So this is one to show this is not only a problem of one continent, so both continents are impacted. Next slide, please. So what is global surgery? It's a rapidly developing multidisciplinary field. You kind of heard it from my example with the boy. A lot of skilled people are involved to perform this one correction of a fracture. And it's an area of study and research to improve health outcome for health equity for all people in crisis. And this is commonly mentioned as the neglected stepchild of global health, to put it a bit more comically, but really meaning that global surgery has such a bad coverage at this time. It really needs to improve in order to change our global burden of disease as well. And we're saying global, so this is not only an issue of low-income countries, which is kind of contradictory to the last pie charts, but even in our country right now, there are people that don't have access to proper surgery due to other constrictive needs. Next slide, please. So providing surgical care, if we just took the example of going to a low-income country or setting up an education hub there, would you need a few surgeons, anesthesiologists, instruments, and sterile fields? Is it that simple? It's not, but in order to get these infrastructures more improved locally, we have to get on a train together and work together with all these different disciplines. So are you ready to board the flight? Sadly, no. Currently, the resources are not there yet, and this is why another reasoning why this advocacy is so important to us, to provide safely, timely, affordable surgery for all groups And if you look at what is needed for that, it's divided in between this kind of flower diagram of different areas that need improvement. One being community health workers, very important. A lot of people from Instagram think that global surgery is taking up an internship in Tanzania, for example, and standing in the surgery room taking pictures. It's actually no, you actually need to avoid medical tourism and understand the local culture, and community health workers can help a lot in bridging both expertises together. Others are infrastructure, equipment and supplies, essential medicines, and of course, trained personnel, and so much more. Next slide, please. So global health can essentially be divided into these different disciplines that you need from a rather more medical perspective. So really important, a lot of people think that it's just the surgeons in a common sense, but the obstetricians, the anesthesiologists are equally important in this story to make those 5 billion people reduce by 2050. And obstetricians, this is the course why we wanted to provide more information on the maternal health as such within global surgery. Next slide, please. All right, so what is Incision specifically? It's the International Student Surgical Network, meaning that medical students all around the globe got together to form a well-developed community and wanted to help out to improve this current number of 5 billion. And it was founded in 2014 and currently has over 5,000 members in the coordinating teams, uncountable members in all between the subcommittees. It's active with national working groups in over 80 countries. We just had our meeting with the other national working groups last week, and it's amazing to see what they're all doing. You could find more information on the website. So of the 45 national working groups that are currently organizing workshops like these, but also research and further advocacy together with the partners such as Doctors Without Borders or WHO. Next slide, please. Great. So back to Incision, and preferably Incision Belgium, of what we're all here for today. We have a liaison function together with BEMSA because we feel that their core mission is quite similar to us in order to improve education within medical students. So this goes in within the first pillar of education where the workshops get organized. We also have some other pillars nationally and internationally based on advocacy and research. You might have filled out our global surgery survey last year that we're writing up an article on right now. Next slide, please. Great, I'm gonna hand over to Brit. She is our amazing colleague and she is the organizer of this workshop and one of the experts by now on maternal health and rights. Go ahead.
Thank you, Eva, for the introduction to Incision. So now I'd like to officially welcome you to our workshop of today, Maternal Health Awareness. As Eva already mentioned, one of our pillars is education. So the goal of today's workshop will really be to confront you with some statistics surrounding maternal health. And then also on the topic of abortion, we have a speaker present today about which I will tell you more later. As some of you probably know, our session today is part of a big day on maternal health in cooperation with BEMSA. For those of you who already joined this session at 1 p.m., I hope it was interesting and you took something away from it. And I hope today's session will do the same for you. To start off, I would like to have an idea about your knowledge on the topic. So we are going to start off with a quiz on Mentimeter. You can join the Mentimeter by going to www.mentimeter.com and by giving in the following code. If it's going to work. Maybe I will go to the code back so you can enter it. Let me know if it works or if it doesn't. Can everybody see the Mentimeter?
Hybrid, yes, I've logged in. Can you see it on the main screen?
I'm trying, but it's a different code, so I don't know.
If you want, I can share my screen. I think mine's
Yeah, maybe
showing
that's
better. Can you see my screen?
Yeah, I can see your screen.
Great. Are we ready to go?
Yeah, I think so. So it's competitive, so try your best. For those of you who followed our social media, it will be a little bit easier because we actually already gave the answers online. Okay.
Some mixed answers, right, Beth?
Yeah, I'm surprised. Okay. More or less, everybody had some different answers, but most of you got them right. Okay, congratulations, Snuggles and Tom. Oh, congratulations to the winner.
Sorry, that was me to test it out. So I think the real
Okay.
winner is probably Milena.
Okay, congratulations, Milena. Okay, so I will now share the PowerPoint again. Yeah. Okay, so as you saw in the answers, indeed, more than 800 women die every day from complications related to pregnancy or childbirth. That number is a bit abstract. So if you make the calculation, you can see that it's one woman every 2 minutes that is dying due to complications. So if you look at the time right now, the session is already 20 minutes in. That means that in this time already 10 women died. And I have to say that the first time I read this quote, it hasn't left me ever since. So I think it's really a strong quote and a strong number and statistic that shows you the problem, that it's a really big problem. And 49% of these occur in low and lower middle income countries. Then the topic, the question about abortion. Indeed, 45% of all of the abortions happening worldwide are happening in unsafe conditions. And 79% of these are, again, happening in low and middle income countries. So that's even more than the complications related to childbirth.
Great.
Okay.
I think it's my part again.
Yeah, it's your part again.
All right, super. So how can we fix this? If we know that every 2 minutes one woman dies, I mean, those numbers, as Britt mentioned, are just gruesome. The main challenges, this has been studied quite broadly into multiple articles, and they've all come to a consensus that the main challenge is promoting maternal health care utilization in resource limited settings. Initially you might think the problem is the fact that they can't have access. That is true, but it's only part of the problem. In areas where they do have access, the promotion of utilizing it is more needed, and Britt will explain a bit more on that in a second. Are surrounding those of accessibility. So like I said, the other part of the problem is the infrastructure, skilled human resources, technological and financial for the health system. But the second part of the problem is equally important, is to improve insight within health, self-efficacy and behavioral factors at an individual level. And that has shown to be one of the most difficult ones, because this is behavioral factors that have been passed on from generations, and is very difficult to convince. Next slide, please. Great, so now we have one figure of the studies showing the prevalence of utilizing antenatal care and skilled birth assistance in Asia. And there you can see there's quite a big discrepancy where the availability is measured at 100. You see of those 100 units, how many are being utilized. And then you can see in places like Laos and Yemen, Pakistan, the utilizing of antenatal care, and then on the right, the skilled birth assistance is quite low, going down to 17, 30, 40. That means if you look at the whole graph, around only 2 in 3 utilize the system, the infrastructure for antenatal care and skilled birth assistance. Luckily, there has been some improvement in the last decade, so this is quite a recent figure in most countries, but you can see still some countries don't really utilize the infrastructure available. Next slide, please. So, remarkable progress. High maternal mortality rates continue to persist, meaning that the remarkable progress, there has been a lot of investment in improving maternal health care, especially if you know these statistics of the 800 women. So what have they done? They've investigated what will it make a substantial difference in the way it's being utilized right now. And this is the second part of the problem that we mentioned, is that mortality rates continue to persist, especially across Asia and Africa, where large of the parts of the women do not avail essential maternal health care services, such as antenatal care. And there you can see it, the last one was as well in Asia, and if you compare it on the left to the services in Europe, you can see already the big difference in utilizing. So we do have some work, but luckily we're not alone, and being informed is the first step. The second step is taking action, but Dr. Mpoyi is going to tell you a bit more about that in a second. Next slide, please. Over to Britt.
Okay, so here you can see the Sustainable Development Goals. There are 17 in total, 6 of which can be applied to global surgery in general. And then the 3 that are highlighted here, namely 3, 5, and 10, can be applied to maternal health. So we are going to zoom in on the following one. Yeah. So Sustainable Development Goal 3, Target 3.1 states that by 2030, we have to reduce the global maternal mortality ratio to less than 70 per 100,000 live births. And we see that between 2010 and 2014, the global maternal mortality rate decreased by 44%. But in 2017, there were still 211 per 100,000 live births as maternal mortality ratio. So we still have a long way to go to reach that goal by 2030. Then also the proportion of births attended by skilled personnel increased in all world regions from 59% to 71%. So that's also an improvement. But if you think about the number 71%, then that means that still 1 in 4 babies is being delivered without skilled care and by untrained personnel. So who are these untrained personnel? Well, in remote regional areas such as Mexico, indigenous providers and family members assist with births, but they do not have the right understanding of complications. Take, for instance, hemorrhage. It's the #1 leading complication in maternal mortality and deliveries. So if you look up the number, then you see that between 2 to 4% and to 6% after vaginal and cesarean section, you have an occurrence of the postpartum hemorrhage. And in a study, they asked these untrained personnel, well, how do you treat this? And they answered, well, we just give the woman some chamomile tea in order to clot the blood. But of course, that's not the right treatment for hemorrhage, and women can really die because they bleed out, they bleed to death. So the leading cause of maternal mortality, as I said already, hemorrhage accounts for 25 to 43% of all the maternal mortality ratios. Then the point underneath, you see the communal decision. What that means is that the decision to seek out trained care and to go to a hospital is not always in the hands of the woman herself. Again, in the same study, there was asked at the woman, well, why don't you reach out to doctors? And the answer was, well, I wanted to go to the hospital, but my husband and my mother-in-law would not allow me because I was not sick, I was just pregnant. So as Eva said before, these behaviors are really given from generation to generation, and it's an obstacle in seeking out care for these women. And if we take a look at target 5.6 of Sustainable Development Goal 5, we see that by 2030, they want to ensure universal access to sexual and reproductive health care. And later on, we will explain that this is a very important step in preventing unsafe abortion. Okay, so now we will focus on the topic of unsafe abortion itself. Before we do that, I will give you the definition from the WHO. So they determine an unsafe abortion as the following: a procedure for terminating an unintended pregnancy carried out either by persons lacking the necessary skills or in an environment that does not conform to minimal medical standards. So if one of these conditions is checked off, then we can talk about an unsafe abortion. And if we apply the following definition to the world, we can see that in total, there are 73 million abortions taking place each year worldwide. And as you saw in the quiz, 45% of these are unsafe. And of these unsafe abortions, 79% take place in low and middle income countries. So if you then take a look at the color coding in the circle, you can see an orange part and a red part. The red part accounts for the worst conditions. So what does this mean? It means that the abortion is carried out by an untrained person, but also by using dangerous methods. If we then take a look at the distribution of these abortions, you can see that the shape of the circle, the white circle, represents all of the abortions happening in the continent. So we see Asia as a leading continent on the amount of abortions happening. But then again, if we take a look at these color codings, for instance, Africa, you can see that nearly half of all of these abortions are happening in the least safe conditions. So without a trained doctor and in minimal medical standards. So if you then add the orange part to that, you can see that in Africa, just 1/4 in all of the abortions are happening safely. So that's not enough. The same goes for Latin America. And if you look at Asia, it's also not that promising. North America and Europe are doing better as developed regions. And if you take a look at the numbers underneath, you can see that in developed regions, 30 women die for every 100,000 unsafe abortions. But if you then take a look at the developing countries, that number increases to 220. And in sub-Saharan Africa, we see 520 women dying for every 100,000 unsafe abortions. So we also see that there is an imbalance in these numbers. So where does this problem take root? For instance, the continent of Africa accounts for 29% of all of the unsafe abortions, but 62% of all of the abortion-related deaths. So again, the same imbalance. Where does this problem take root? In the complications. So after an unsafe abortion, women experience complications such as an incomplete abortion. This means that there is still some tissue of the fetus left in the uterus. This can cause, again, hemorrhage, infection, and uterine perforation. We also see damage to the genital tract and internal organs because the women insert dangerous objects such as sticks, knitting needles, or broken glass into the vagina or anus. It's not that we don't see these complications in Belgium. We see the same complications, but we can diagnose and we can treat them earlier. And as you will see in videos that I will show you, women in Belgium are also more likely to seek out care. They are more likely to go to a hospital if they experience these complications, because in developing regions, most of the women are living in rural areas and they don't have access to a hospital or a trained doctor. Then all of these complications and these abortion-related deaths account for 13% of all of the maternal deaths globally. So that's, next to hemorrhage and preeclampsia, a really big reason for maternal deaths globally. And 5 million women are admitted to the hospital every year, and this accounts for a budget of $680 million. So these are enormous numbers. And then how can we prevent this? How can we decrease these numbers? That's really by making sure that the root of the problem is, we change the root of the problem. And what is the root of the problem? That is that there are restrictive laws. If there is a restrictive law in a country, women will still get abortions. They will just get them unsafely. So we have to prevent this. But if you look at the current situation, you can see on the map of the world that below you can see that all of these countries, most of them have restrictive laws. And 40% of women of reproductive age are living in a country where abortion remains highly restrictive. And nearly all of these, as I said, are low and middle income countries. I will now talk shortly about the procedure of abortion. On the graph, you can see that up to 12 and 14 weeks, we use vacuum aspiration. And then after 12 to 14 weeks, we use dilatation and evacuation. But what I want to show with this figure is actually that under 12 weeks, we can use medical abortion. And this means that a woman can self-manage an abortion at home with the right education from a professional and medication. Because if you take a look at the number from earlier, worldwide each year there are 75 million abortions taking place. We just don't have enough doctors and we don't have enough hospitals to make sure that all of these are happening under safe conditions. But if, for instance, we would give medication to women under 12 weeks and they can self-manage the abortion at home, then we take some of the pressure away from the doctors and the hospitals, and we can make sure that the other abortions after 12 weeks can take place in a hospital under skilled care. Okay, I gave you already a lot of information and a lot of numbers. You probably won't remember all of these, but I just want to give a visual of the problem as broad as possible, and to illustrate what the impact of all of this is on women living in a country where they perform unsafe abortions due to restrictive laws. I want to show you a video from the organization Ipas. Our speaker is also a member of Ipas, but he will tell you more later on about the organization itself. But now I will just show you the video to really show you what the impact of the problem is.
But we can't hear the audio. Is that normal or?
You can't hear the audio?
I can't. I don't know about the others, but I can at least.
Well, I will try again. Maybe it's because I, in my share, I didn't. Yeah, okay. I see the problem. We will try that again. Okay, let me know if you hear it now.
The Rwandan government has made significant strides to advance women's rights. It has the highest proportion of women parliamentarians in the world. Gender rights are enshrined in the Constitution. Yet, For most of Rwanda's modern history, abortion has been illegal. Even though abortion was against the law, that didn't stop women from getting abortions. Every year, 24,000 women and girls need emergency medical treatment from unsafe abortion. It cost the Rwandan government $1.7 million to treat those women and girls. And every year in Rwanda, hundreds of women and girls are harassed, arrested, prosecuted, and imprisoned for illegal abortion. In 2012, the Rwandan government tried to address the problem by modifying its highly restrictive abortion laws, but the law is not working. Before women can get a legal abortion, they need permission from 2 doctors and a judge. There is only 1 doctor for every 17,000 people in the entire country. The majority of Rwandans live in a rural area with limited access to court or hospitals.
Most of the Rwandese don't have access to a doctor. Their first interaction with the health facility is with a nurse, a midwife. You're talking about now a facility that is taking care of about 300,000 people. There are a lot of bureaucratic challenges that sometimes may take time, and it may not be easy for that woman to access those services.
The law doesn't stop women from getting abortion. They just do so under unsafe conditions. And they get hurt.
I used to work in one of the busiest hospitals here in Kigali, and we used to get about 1 or 2 abortion cases every day.
Nakoresheje isabune ya omo na glycerine.
They take their drug or whatever they use to abort. Then they fear to go to the hospital. They fear to tell their neighbors because most of them get hemorrhage. And they fear to tell people, then they die. There is one neighbor who died in the bed because she was in the bed, she aborted in the bed, she closed her door in the room, and she couldn't even tell her mother who was in the next room.
Women who get abortions without authorization are considered criminals.
They don't give these women who come in respect. They don't treat them appropriately sometimes. You can find a patient coming in and then after a few hours she's gone because maybe she has not been treated in the right way, or she feels that she has been hearing rumors that maybe she carried out an unsafe abortion and maybe the police is coming to get her.
Maze kumfata banjyana kuri polisi Kacyiru. Banjyanye kuri polisi Kacyiru rero nibwo nahise mbacika.
Ntabwo badukubita ahubwo bagafata amayire bonyine ariko ntabwo badukubita. Rwose bagafata nk'umwicanyi ntabwo wishe.
The Rwanda government should continue reading the word on gender rights by addressing unsafe abortion. To meet its promises to protect the well-being of all people in the country, the government of Rwanda should release all women, girls, and healthcare professionals who are in jail as a result of punitive abortion laws. Eliminate the need for women to get permission from a judge or doctor before she can get an abortion. Increase access to safe and illegal abortion in Rwanda.
Ntabwo bamuhana kubera ko nta bushobozi biyikura mu byishimo. Murabona ngiye mfite amahame menshi ntabwo bamfasha.
Okay, so I think that video really shows the scope of the problem, the impact on the lives of women who don't have access to safe abortion. I listed some of the barriers here. As they said in the video, poor availability of services. There is only one doctor for every 17,000 people. And a lot of these women are living in rural areas and don't have access to a hospital. Then also the laws that are restrictive, the high cost of an abortion, and the stigma. You can see they don't want to tell their neighbors. They are afraid to go to the doctors because of the stigma in the country. Then also the consensus objection of healthcare providers. One of the doctors in the videos told us that sometimes women get into the ER and they are not treated with the right respect. And I think that is unbelievable. Then also the unnecessary requirements. Like they said in Rwanda, they have to have permission of 2 doctors and 1 judge in order to get a safe abortion. So all of these things take a lot of time and they delay the care that they need, and eventually they result in an unsafe abortion. Now, to make all of this a bit more optimistic, how can we prevent this? First of all, good sexuality education. We can educate the women, we can educate doctors, but also what we are doing today, education is really a big part of the prevention. So you are also contributing right now to the solution of the problem. Then also prevention of unintended pregnancy. Like I said before, Sustainable Development Goal 5, by giving access to anti-conception and emergency anti-conception, we can prevent the unintended pregnancy. And then last but not least, provision of safe and legal abortion by changing the laws. This was a lot, I know, a lot of information on short time. If you have any questions, you can ask them in the chat or in the Mentimeter. But I hope that right now at this moment, you all have one question in mind, and that is, what can we do to help as future doctors in training or as doctors? For that, I am presenting you our speaker, Dr. Mike Mpoyi. He is a program manager at Ipas. Like I told you before, the video from the organization. He will talk about the organization itself, but essentially what does Ipas do? It creates abortion ecosystem around the world, and they focus on expanding access to sexual and reproductive health and rights for vulnerable populations. Dr. Mpoyi himself is right now working in DRC, and he is a medical doctor and a public health expert. So I would like to welcome Dr. Mpoyi. First of all, I would like to thank him very much for being here today, for making time and the effort to present and to share your experience with the students present today. I think it will be very interesting. So up to you, Dr. Mpoyi. I will stop the share and start your PowerPoint.
Thank you, Britt, and hi, everyone. Really glad to be here and to share with you our little experience. I think we've had a lot of information from the presentation, and we can see the magnitude of unsafe abortion in Africa and how it hurts women's life. And Ipas is an international organization that really focus on expanding access to sexual and reproductive health, and especially abortion and contraception service. So I'll be talking with you today, maybe for 30 minutes. I'll do a small presentation of Ipas, and I will talk about the approach Ipas use to sustain like access to abortion in countries where we have programs. And then I will talk about the context that frames women and girls' life and ability. And then we can finish by saying what we can do as doctors or medical students to support the improvement of sustainable abortion ecosystem. Next slide, please. So Ipas is an international organization that's really focused on expanding access to abortion contraception. And we started working in 1973 with the provision of the life-saving reproductive health technologies for health system in several countries. So we developed the manual vacuum aspiration and a strong comprehensive abortion care training curriculum and quality of care monitoring SOPs. And Ipas works with diverse local, regional, and international partners toward the goal of reproductive justice, a world where all women rights are respected, protected, and fulfilled. So we strive to integrate abortion rights into the broader movement of healthcare access, gender equality, and social justice. Next slide, please. So this approach of sustainable abortion ecosystem, why about abortion, just abortion? Why just sustainable abortion ecosystem? Why not sustainable reproductive health ecosystem? I think it's a question that's really come to us when we're presenting about this. But next slide, please. We will see that when abortion is denied, it's a signal that something bigger is going very wrong. People aren't being trusted to make most basic and personal decision in their lives. If a person is denied reproductive freedom by being denied an abortion, it's their human dignity, liberty, and equality that are now at stake. So the status of abortion will tell you very quickly if women and girls' rights are being respected more generally. If we direct our effort on abortion, linking our work to broader gender and health justice movement, and even beyond, we will quickly see that we have a very important perspective to offer the movements beyond the abortion ecosystem. If we can make the abortion ecosystem sustainable, perhaps we're supporting and improving the foundation on which other rights and freedoms can be realized. Next slide, please. So this is the sustainable ecosystem framework. And you can see that in the center, there is the sustainable abortion ecosystem. Sustainable care, sustainable access to abortion, it means the 8 components surrounding the cycle need to be kept stable and improved throughout the process. In the middle, there is women. It's her need first. This model of care is centered on women need. And around you have the components that are playing together to have sustainable access to abortion care. So you have policy and legislation that need to be improved to sustain access to abortion. You have individual knowledge and agency. You have community and social norms and support. When we're talking about stigma, it's community. It's community that are pushing women to clandestinity. Health information need to be available. We need to have data. We need to have source of evidence-based information that can be shared to support the advocacy and to support the continuous improvement of quality of care. Health workforce and service delivery that need to be ensured, because if providers are not trained, you can't expect to have different results from the service that will be delivered than seeing complication going forward. Commodity, it's one of it. Without commodity, no program, no service. Financing, healthcare financing system need to be improved, and political support and leadership. Those 8 components are really important to be improved to get sustainable access to abortion service. And around them, you will see that we have the 4 engines that are like human rights and equity that need to be ensured throughout the program, the partnership and collaboration that need to be promoted, because this ecosystem, it's not depending only on one organization making it stable. It depends on partnership, collaboration of institution, organization to move this forward. Local expertise need to be promoted, and ownership and accountability is a key element to make this sustainable abortion ecosystem stable and provide abortion service to women. Next slide, please. In the next slide, we have these different components of the ecosystem interacting between them. You can see that individual knowledge and agency and communities and social norms play a key role in creating a kind of political support and leadership. Because when you have community advocating to have access to abortion, political leaders will be obliged to take decision and make that available. And when you have political support and leadership established, they can sign papers, bills to have commodity available, to have the financing system available, established, and to have policy and legislation developed to make access to abortion sustainable. And then you can see that the health workforce and service delivery will be maintained and improved. So these different components are interacting, supporting each other in a way that when women are going to health facility, they can really see all these process transformed in health service for her. Because as we say, abortion is essential care. Next slide, please. The next slide is about the work that Ipas has done in DRC. Because you will see that DRC is coming from a really restrictive law situation and policy. And we needed to have actions to change the situation. Next slide, please. So this is the context in which the program started, the intervention in DRC, because we had a penal code from 1940 that was punishing abortion, punishing contraception. Even just talking about abortion was punished by the law. So people were arrested. Providers who were trying to provide service, abortion service to women, were arrested. And we are in a setting where you have unfavorable social, cultural, health, and economic context for women, a context marked by significant inequalities of consideration, treatment with the community, where women are victims of different kinds of violence, rape, incest, sexual assault, early forced marriage, sequestration, kidnapping. All these retrograde social norms have created a degrading environment for the improvement of women's condition. You can see that in 2018, 35,000 gender-based violence case was reported, and that doubled in 2020, as you can see. We had an inheritance of restrictive abortion policies and law, as I said, social norms depriving women from their bodily autonomy. In public health, it was being noticed, 61% of pregnancies are unplanned in DRC. 43% of those unplanned pregnancies will end in abortion, and 27% of teenagers aged from 15 to 19 already have a child or are pregnant with the first child. That is the situation. And the maternal mortality rate in DRC is about 693 deaths per each 100,000 live births. And DRC is one of the 6 major countries contributing to half of the global burden of maternal mortality, and abortion is the second one. 17% of maternal mortality in DRC is due to abortion. That is representing about a woman dying every 2 hours. That is the context in which the country is. And when you compare that to the sustainable goal for like durable development, you'll see that we have a big gap to go from 693 women dying per 100,000 childbirth. It's a lot, and there is no miracle. We advocated with the government to have the law changed. And you can see, has already said, that highly restrictive laws do not eliminate abortion. Rather, they make the abortion that do occur more likely to be unsafe. So countries with restrictive laws, they even have a bigger rate of abortion than countries where abortion is allowed on demand. Next slide, please. So from that, we advocated with the government to have a legal and policy change. And that was not easier because as I said, we had a penal code from 1940 that was still applied, punishing women, doctors, community people involved in referral mechanism to safe abortion. So over the past 4 years, the DRC has seen drastic change in the legal framework, shifting from a very restrictive to progressive setting regarding sexual reproductive health and rights, particularly the right to safe abortion, allowing contraception and abortion to be legal in the country. And Ipas with continued and flexible donation has played a critical role in achieving these milestones. Next slide, please. So this is showing what is the environment, like legal and policy environment at the time being. We have the Maputo Protocol, which is like a regional African treaty signed by different countries, in which the Article 14 is talking about the sexual and reproductive health, and especially talking about the access to abortion. And DRC has signed that document without reserve, saying that they will apply it, they will fully apply it. And that was the point of advocacy, because at that time, this treaty, Maputo Protocol, was not yet published in the official gazette of the country. So IPAS advocated with other stakeholders to get this document published. And as our constitution stated, when a regional or international treaty is published at the National Gazette, it is becoming an internal law. So that was like over the penal code that was punishing abortion. And this Maputo Protocol is the main law that we use currently in DRC to provide abortion service to women. And after this, we advocated with the Constitutional Court because we saw that judge and magistrate, they wanted more interpretation of the 14th article of the Maputo Protocol. So the Constitutional Court was seized and they interpret and said that the Article 14 shall be applied and the judge and magistrate should use Maputo Protocol as a law to process the trial. So that was a key element that added to the availability of the law, the Maputo Protocol, and fueled the fact that the judiciary system was sensitized and informed about the existence of Maputo Protocol. And then we had in the COVID period, in the National Response Plan, we had advocated to have the access to abortion as an essential care that should be sustained during that period of emergency. And lastly, we had the comprehensive abortion standard and guidelines endorsed by the Ministry of Health after a long process of elaboration and validation. And you see that in this process, we had doctors like the National Society of OBGYN who were involved in this process. We had the board of doctors. We had all the doctors involved in this policy change. They were supporting the process because they were the first in the front line. They were the one facing the arrests, the harassments from the judiciary system, from the law enforcement officers. So they were involved to see the change and to make this affordable and accessible for women. Next slide, please. And here you can see this document is just the authorization that the Constitutional Court, which is like the highest level of the court in DRC, who authorized Ipas to train all the first presidents of appeal court throughout the country and the general prosecutors on Maputo Protocol, and especially the Article 14 that is allowing women to have access to abortion for rape, for incest, for when the pregnancy is endangering women or fetus life, or when mental health is endangered too. So for these indication, women can have access to abortion. So when you talk about mental health, you can see how wider that is to make possible abortion to all women that can be in need. And lastly, you have the official journal, a law that was voted in 2018 that was stating some aspect of Maputo Protocol, like for access to abortion. Next slide, please. So this is like concerning the policy change. As you can see, can you go back?
Yeah, sorry, I will, I accidentally stopped the share.
Okay.
To what slide? 15?
13.
13, okay.
Yeah.
Yeah.
Thank you. So what all I've talked about is mostly what happened to change the policy and legal components of the ecosystem. And in this time, we've strengthened and built a political and leadership support to have this process move forward. But at the other side, women needed to access service. That's the reason why we were supporting the health system at the other side to start initiate like sites to provide abortion services to women. And that was the work that we've done on developing the standard and guidelines for comprehensive abortion care. And the other side, we had the authorization to have the mifepristone and misoprostol available in the country, and to have the MVA accepted to be like a ship in the country and used as a method to have access to abortion. And then we had developed a training tools and mentorship to train providers and impact on the kind of the quality of service that they were providing in health facilities. And since 2018, we had several women, thousands of women that had access to abortion service in DRC throughout the intervention. And within the COVID period, we had developed the telehealth that could allow women to have access to abortion in that period where the health system was overwhelmed by the management of COVID cases and the time that even the financial resource of the government was mostly routed to fight the the COVID pandemic at that time. So the telehealth helped a lot to have women sustain the access to abortion service, when it is needed. And we had providers, we had application, telehealth application, digital tools that was used to provide information to women. She could still access information even if the community health workers couldn't go out to provide those information. So the digital helped a lot to keep the access to services during that emergency situation. We have supported the Minister of Health to have a national task force of quality of care that will be focusing mostly on evaluating, assessing, monitoring the quality of care, like abortion services in health facilities. All of that just to make sure that we don't fall in the same problem of having a bad quality service provided to women, and we could have a backlash like from the community system, from the leadership saying that the service that is provided is now creating all the problems. So we just need to make sure that all the safeguards are installed to make sure that the quality of service is ensured. And we've supported the Minister of Health to design the indicators for to be integrated in the National Health Information System. So that will allow the health system to be strengthened enough to be able to take in charge the abortion service provision and even beyond, because when women can't have, they can't go to the health facility, they can still have information through the digital tools, and they can go to the pharmacy, get drugs, and self-manage the abortion from home. Or they can call a hotline that we're supporting to have access to a provider that can accompany them throughout this process. So this is what is done from the health system side, and from the time being, it works, we can say, really well. Next slide, please. And in this slide, you can see that the community engagement and partnership was promoted throughout this process. Because as you can see in the abortion ecosystem, if the social norm is not improved, if the different negative habits and traditions are not lifted, women will still experience stigma and would be pushed to clandestinity. That is the reason why the community system, community counterpart or stakeholders are really involved in this work to create a community engagement and improve the support for women at the community level, so that she can have access to information at the community level. She can be referred to health facility when needed, or she can find the reliable source of orientation at the community level. And you'll see that usually in DRC, it has been stated in a survey that 80% of adolescents, when they are pregnant, 80% will seek for abortion, whatever situation, whatever condition, or what, they will seek first for abortion. And the highest level of mortality is noticeable with adolescents in the country. Next slide, please. Yeah, this is just the online campaign that are organized with youth organization, women-led organization, to make available the information and ensure the referral mechanism to health facilities. Next slide, please. So, yeah. So you can see that the community stakeholder is really, really a key element in this. So in the next slide, we'll be talking about the context that is framing like women ability. Let's consider a girl named Mila in the Netherlands, where the fertility rate is quite low at 1.6 children per woman. There is a high likelihood that Mila will finish her high school and go on to the university. During her primary and secondary school years, Mila will receive comprehensive sexuality education. If she wants it, free contraception is available to Mila. If Mila needs to have an abortion, she can get a safe and legal one. If she chooses to have children, Mila in Netherlands will get high-quality maternal health care. And there is a comprehensive childcare system to assist her throughout this process. Because Mila has had the opportunity to get an education and go to college, she can enter the workforce. As she ages, Mila can earn a good living and contribute to her community and country. Her life expectancy is 83 years. Next slide, please. And the next slide, we will see a situation of some of my friends, like girl. I remember we were little, like here in DRC, about 11 to 12 years old. Our girlfriends were withdrawn from our play groups, torn from the innocence of their childhood. We could see them passing by, held by their husbands. We couldn't even understand what was happening to them because we're just child. Today, I'm a medical doctor, but our friends, girl, they have 6 to 10 kids. They have hardly finished their elementary school. They don't work. They're fully dependent on their partners. They did not go to antenatal care. You know, the gestational age, they count the apparition of moon and estimate. They have been told to visit hospital only while they are ready to deliver. In those emergencies, no time to do ultrasound or any other test. Usually it is about chance. As the couple knows, they do not have funds to pay the service at the hospital. Men won't show up at the hospital. It is interns, doctors giving the money to pay necessary outfit for the baby and for the women. And sometimes it goes well, and some other times they pass away. So that is a case like of one of my friends. And Melu's life expectancy is just 61 years. Next slide, please. This is the situation in which women in DRC are living. So what can we do as doctors and medical students to help improve the sustainable abortion ecosystem? This is you need to be part of a dynamic that is bigger than just your own person. You can make a difference around the world. And for that, volunteering is really important. In my career, I started first by volunteering when I was a student. And that helped me to envision healthcare beyond service delivery only. I started as peer educator. I was providing information in my community, sensitizing people, provide accurate and reliable information to women and girls, to fight stigma in the community for women seeking for abortion. But as a medical student, You can still advocate for law and policy change at a global level. You can be part of this advocacy that is done to have global system changing, pressuring countries to improve their law and policy framework. You can be involved in generating evidence to support the advocacy work and continuous quality of care improvement. That's the things that we can do. Volunteering is a really big part of it. And when we doctors, we can do all of the volunteering, but we can provide sexual and reproductive health services, including abortion, free of discrimination and stigma. And we can explore new paths to care. As we were talking early about abortion self-care, you can advocate for health financing system to be improved. You can donate to support organization, peoples, women that are experiencing difficulties to have access to reliable, good quality sexual and reproductive health. Those are things that we can do to support, improve the situation. And that is part of the sustainable abortion ecosystem. It's things that we can do to improve it and make it stable so that women can have access to abortion services throughout the globe. Next slide. Thank you, please. Thank you so much for your time. Thank you. So I'll hand over to Britt if there is questions. Thank you.
Thank you for the presentation. I think it was very interesting. The conversations you made between a girl from the Netherlands and also talking about the abortion ecosystem, the situation in Congo. So I think it was very interesting. I hope the students present think the same. I will first like to know, we still have some 10 minutes left for questions. Are there some questions from the audience? You can put them in the chat or you can unmute yourself and ask your question. I don't know, Eva, if there are some questions in the Mentimeter.
Not coming in though, but I did submit my question to you, if that's possible to ask.
Yeah, if you can also ask them yourself. If you want
okay. To. Yeah, sure. So what I was wondering, let me just put on my camera. Thank you, Mpoyi, for your great presentation. I must say it's been revolutionary, and I really love the fact that you provided the entire sustainable landscape. You touched on it a bit about the medical student's role. We get that question a lot: is what can you do to help? Could you maybe give some more concrete information? You mentioned learning and the education on how to perform a safe abortion. Is that the way forward? Should we be advocating for that, or how should we prioritize our advocacy?
Thank you so much for asking. I think as a medical student, we can't, like, as known, we can't provide abortion service, but we can make available the information. We can work, for example, on like doing social media campaign, for example, making available the reliable information and fight the misinformation that is spread throughout the globe, because you will see that the opposition components, opposition to abortion, they're using several pathways and to spread misinformation, rumors in the community. So as medical students, we can do that to make that available. And in our community, and even through the organizations that are working on the field, we can advocate, we can be involved in volunteering, supporting some actions that are going in the way of like reducing stigma in the field. So that can be identified at the country level, which kind of organization that are, for example, fighting for like women bodily autonomy and access to abortion. So you can be involved in that kind of actions and help to reduce stigma. And you can, at maybe global level, like when WHO is drafting the policy and guidance, like when there are international conference uniting like countries from Africa and all over the world, students can be in those kind of conference. They can talk and advocate to have change seen in Africa about policy and legal change. Those are things that we can do, and we can work on evidences. Like in our thesis, in our survey that we're doing, we can work on abortion-related subjects and make evidence available. So that's the ways that we can, as students, be involved in improving the sustainable abortion ecosystem. But I know there are several other ways that people can support the work.
Thank you for that. I think that's very practical examples and very, low investments, so to speak, in terms of time. We can use our social media channels to spread that knowledge and ask the stakeholders to reshare our posts. And Brits is moving forward into advocacy. So thank you for giving these practical examples, and we hope to follow up as well as possible with them.
Thank you, Eva.
I see there is a question in the chat. Maybe you can answer that. I was wondering if there are current initiatives to strengthen SRH education.
Yeah, in the organization, yes, we do have, but even at the country level with the government, we're advocating to have like initiatives or to have like the comprehensive sexual education to be made available for students and people at elementary, like at high school, at elementary school. So that's at each level of the when people are growing up, they can have adapted sexual comprehensive sexual education provided to them. That is something that we're doing with the government, and we're trying to make that integrated in the education models. But at the community level too, we have community health workers and women-led and youth-led organization doing sensitization and awareness at the community level to provide education to those who are not attending school, so that they can be reached at that at that point too.
Okay, thank you. Does that answer your question? I hope it does.
Yes, it does. Thank you so much.
I saw that Jolien unmuted herself. Do you have a question, Jolien?
Yeah, sorry. I had a question, but I think it's not so easy to answer. But I was wondering, what is your point of view on the role of politics in this kind of education and helping people to see the other ways to save abortion?
I didn't get the start well. Can you come again?
Yes, of course. What do you think is the role of politics, like politics in one country and also international politics, in helping people to advise and give them a layout of the opportunities there are to get safe abortion?
I think the politics have, one of the highest position in this process, because you see that when there are not policy, when there are not political leadership support, we can't move forward. It will be like arrest and punishment and all of it. But when you have political and leadership support, you have maybe policy signed, release to make access to abortion possible in the country. You have law change to have to provide access to abortion. So that is are things that politicians or politics can do to support the sustainable abortion ecosystem. And at the other side, you'll see that they are influencers in their different community. So when you have them, they can talk to the community and create a kind of community engagement and change understanding of the community and reduce stigma. That's things that they can do because they have this possibility to talk to the mass, to talk to the population and be understood. So I think at the global level, I think usually we have treaties that are signed at the global level, like led by countries like European or Western or African. Those treaties usually it is giving a way to countries to take that as a way of accountability. Because when you have a treaty that is signed at the global level, the country will try to align to that treaty and integrate that in the country, in the livelihood of people. So I think when you have a global situation like that, it's really impact the country and it can contribute to improve the situation. So that's things that I can cite here to show how political engagement is really key element in the improving of the sustainable abortion ecosystem.
Thank you so much.
I don't know if I got it. Yeah.
Yeah, thank you.
Thank you, Julian.
Are there some other questions? Because else I still have a question. You talk a lot about the stigma that is still there with people. And I was wondering, you can change a law, but then you still have to change the mindset of the people, because you can make abortion accessible, but maybe they won't go because, as we talked about in the presentation, the decision to seek out care is not always in the hands of the woman herself. And you talked about in DRC that you are doing community engagement by giving some workshops. Can you elaborate a bit on that? How do you do that? What do these engagements and these workshops, how are they organized?
Thank you so much, Britt. I think at the community level, as you said, when you have like stigma in the community, usually women don't have this possibility to go freely at the health facility and seek for service. And that is bringing like the social behavior change, because we need to change that. We need to impact on social behavior. And as the program, we have a strategy, we have a tool that we call shifting gear for social behavior change that we use at the community level. First, to assess what is the level, what is the problem in the community? Is it tradition? Is it social norms? Is it like religion? What is it exactly? And we identify the point of action. And then we have another tool that we call VCAT, like value clarification for attitude transformation for abortion. And it's a kind of exercise that we bring people through. And it is an open discussion with community leaders, people from organizations, civil society organization. We talk with them about abortion. We bring evidence and we tell them, even if you think that it's us here allowing people to have access in abortion, that's not true, because abortion is just because women is women, and we can't talk about abortion with men. So that is bring like a light, and people say, okay, then it's a specific need and we need to think about it. And then having the evidence, it makes people think not as personal conviction, but has a need for the other person. And if you deny the access to abortion, it means it's an injustice that you're creating, and you're just routing women to one path, which is death, and which is, uncertainty about their life. So when you engage that kind of discussion with community people, they get to develop a commitment to support the program. And it will be now them who will be championing that communication at their respective community level. And so we use like a civil society organization, community-based organization. We train them on value clarification for attitude transformation about abortion, and they get to bring that discussion at their community level. So I think it's tough. It's not easy in Africa, where you have really restrictive traditions and social norms, and even like basic need for women are not respected. Like it's a lot of advocacy and awareness activities that need to be implemented. And I think at all level, everyone has this opportunity to contribute to change the social norms. You know, whatever we use, it can be graphics, it can be online campaign, it can be books that are improving and promoting comprehensive sexuality education and all of that. It's important to make sure that the reliable and accurate information is out there, and that can contribute to change at the social norm.
Yeah, thank you for the answer. I think indeed that social media and the online platform, like you talked about, the telehealth in COVID, it's really important that we advocate via social media, because it's a big role of our lives currently, to spread right information and then also go in discussion with the community and see where the barrier is, what the problem is indeed. I think that was very helpful. Thank you. Are there some other questions from the audience? Yeah, I think I see that there are some people that have to leave this session, but it's 4:33, so I don't know if there aren't any questions left. I think that we can conclude this very interesting workshop. Thank you again, Dr. Mpoyi, for your presentation and to share your experience with the students. To the students, thank you for being here, and I really hope that you take something away from the session of today and maybe think about volunteering. There are a lot of possibilities where we can advocate and voice our concerns to the world. So thank you for being here. Thank you, Dr. Mpoyi, for being here, and have a good afternoon, everybody.
Thank you so much.
Britt. Thank you, everyone. Thank you. Bye-bye.
Thank you so much.
Thank you, yeah.
Thank you.